hope you're all well. Thank you for tuning in to our webinar series, Clinical Anaerobic Bacteriology. We're delighted to welcome Dr. Michael Perry to today's webinar, C.Diff Deep Dive. Dr. Perry is a consultant clinical scientist at the UK Anaerobe Reference Unit, part of Public Health Wales and based in Cardiff. There, he leads research and development focused on anaerobic pathogens. His work centres on the use of molecular techniques and whole genome sequencing to better understand diseases caused by anaerobes. This research supports more effective prevention strategies, improved patient management, and robust investigation of outbreaks. In addition to his scientific work, Dr. Perry plays a leading role in the field. He is chair of the Wales Clostridioides difficile infection working group and treasurer of the C.Diff Trust, a charity launched to the public in October 2025. The Trust aims to reduce the harmful impact of Clostridioides difficile infection and to advocate for patients. Today, Dr. Perry will be presenting a deep dive into C. difficile, sharing his expertise on the organism, its clinical impact, and the key challenges and developments shaping how C. diff infections are understood, detected, and managed. If you have any questions, please leave them in the chat box and we will answer them at the end. Thank you, and without further ado, Dr. Michael Perry.
Hi, my name is Michael Perry, and I've been asked by Don Whitley Scientific to present on Clostridioides difficile today. Starting with my disclosures, Don Whitley Scientific very helpfully support our UK Anaerobe Reference Unit annual practical and clinical microbiology of anaerobes course, which we're very grateful for, but that we don't benefit from financially as a department. I'm a trustee of the C.Diff Trust that I'll talk a little bit more about later, and we receive sponsorship from a number of companies. Again, very grateful for their sponsorship. My department benefits from me attending meetings, support attending those meetings, and also honoraria that go to the department from various companies as well. And I have been supported by BMeria in my doctorate work. I have no other disclosures that are relevant to this talk or topic, but you should know that cows are my favourite animals, and that some people find it quite shocking that my wife and I have 6 children. Seriously, the UK Anaerobe Reference Unit is part of Public Health Wales, and we're based in Cardiff at the University Hospital of Wales that you can see there in the top right. We've been a UK Anaerobe reference service for many years now, since the 1980s, and we provide phenotypic ID and susceptibility testing, as well as clinical advice and research in anaerobic microbiology. Whole genome sequencing is rapidly developing, as we all know, and so we are doing a lot of research currently looking at the use of whole genome sequencing for anaerobes. In relation to that, we have been performing whole genome sequencing for C.Diff typing for a number of years now, and we are the Wales reference facility for C.Diff typing. We are fortunate to be able to type all GDH and PCR positive sample isolates that we're able to grow, and we have a UCAS accredited service. I'm a consultant clinical scientist who's worked in the NHS within Wales now for 25 years, working in the Public Health Laboratory System, the National Public Health Service after that, and now Public Health Wales. My expertise is particularly around molecular diagnostics and pathogen typing, and I am the chair of the C. difficile infection working group and a trustee of the C.Diff Trust. And you can see the team there in the bottom right hand corner, which I enjoy working with. A little bit about C. difficile background. It is a bacterial gut commensal that is often found in lots of different environments. We see carriage rates quite high in children and cystic fibrosis patients, and also in animals who can carry it within their guts, and of course on their hides and fur, etc. as well. The ability to sporulate helps C. diff to survive for very long periods in the environment, and spores can also resist many cleaning products that we have, which causes a particular problem in healthcare settings. We have these hypervirulent strains that can also cause problems and have done, thinking of ribotype 027, historically causing very large outbreaks with severe disease and high mortality rates back in the early 2000s. but other strains such as ribotype 027, particularly a One Health pathogen, and more recently ribotype 955, which I'll talk a little bit more about later. Back in 1893, the clinical condition of pseudomembranous colitis was first documented, but it wasn't until 1935 that a couple of researchers published on the organism Bacillus difficile, as they called it back then. In 1978, George and colleagues put C.Diff together with antibiotic-associated diarrhea in terms of C.Diff being one of the main causes of this clinical condition. And even though we've had a few name changes over the years, of course Clostridium difficile as it used to be known, fortunately we've settled on Clostridioides difficile, which means Clostridium-like, and so we can still call it C.Diff. C.Diff is a superbug, as the tabloids would call these things. It is multi-drug resistant, and as a result of this multi-drug resistance, causes many of its problems. Where the gut microbiota is disturbed, we see that C.Diff can colonize and then proliferate. And as it proliferates, we get an increase in toxin production, both toxins A and B, and potentially other toxins such as binary toxin, which cause damage and inflammation to the gut wall. This can lead to a mild diarrhea that can be self-resolving, but it can also lead to very severe diarrhea and potentially death. As I said, in the early 2000s, we saw some very, very high rates of C.Diff with a high degree of mortality and many, many outbreaks. Fortunately, we saw reductions in the late 2000s, and in 2010 to 2018, we saw consistent year-on-year reduced rates. Even though we saw lots and lots of reduction in our hospital-acquired infections, when you look closely at the data, we didn't see many reduced numbers in our community settings. And unfortunately, since 2018-19, certainly here in Wales, in other parts of the UK and the world, big increases in our C. difficile rates have been seen. We've also had some substantial outbreaks, again in UK nations. Fortunately, the fatality rates are low these days, but there is still significant morbidity and service disruption as a result of these infections, and particularly when there are outbreaks. Fortunately, we have seen some green shoots of reductions in rates so far in the 25-26 year, which we are hoping will continue. Diagnostics, of course, are very important in our diagnosis of infections, and C. diff is not alone in that. There are several different types of assays that we can use to detect C. difficile and its toxins. And GDH and PCR tests really are the most sensitive of those. We can also get a high degree of specificity, or at least a higher degree of specificity as opposed to the GDH and PCR tests by using these toxin A and B enzyme immunoassays. But it is fair to say that there is variable performance of these assays, and so it is important to be careful which ones you employ in your particular laboratory. So the ESMIG recommendations are that you use a two-step algorithm, that you harness the high negative predictive value of a GDH or PCR test, and then subsequently, where these are positive, use a higher specificity toxin AB enzyme immunoassay. However, the diagnosis of CDI, as you can see there outlined, should be based on clinical signs and symptoms in combination with laboratory tests. And that's because none of the tests that we use in the laboratory are perfect, and certainly with C. difficile, that is even more the case. And so it can be very challenging to interpret particularly a GDH positive toxin EIA negative result, but also a nucleic acid amplification test toxin AB EIA negative result. Are these patients just colonized, or do they have mild to moderate CDI that should be treated? It's very difficult sometimes to tell. So there is no one diagnostic test that is suitable, and these algorithms should be employed. It's important to recognise that the recently updated UK SMI stipulates now that we should be using a nucleic acid amplification test as a third line test if we are using GDH as our frontline test. And that's because, as I said previously, it's very, very difficult to clinically interpret a GDH positive toxin AB EIA negative result. Ideally, we would also be testing all our community patients because we know from research that quite a few cases in the community are missed because of selective testing. However, there is an acknowledgement in the UK SMI that this has a significant financial impact, and so it is something that is just proposed as ideal where possible. As I said, CDI should be a clinical diagnosis, and it is important to recognise as well that toxin-negative patients, even though they may not clinically have C. difficile infection, are still more than capable of spreading their C. difficile to the environment and to other patients and healthcare professionals, and so shouldn't be ignored. They should be seen as a potential infection risk to others as well as themselves, of course. We are hopeful that future developments in ultrasensitive toxin assays may provide us with better testing for C. difficile infection, but these really are some way away if they ever come to fruition at all. What we saw when we changed from a GDH assay to a nucleic acid amplification test for our initial screening of patients with C. difficile infection, we didn't see the big increases in detections that people were worried about. And the reason for that is that we were no longer detecting strains that didn't have the toxin B gene and so didn't have the toxigenic potential of other strains. We know that there are also toxin variable strains such as Ribotype 026, and again we were no longer detecting those that didn't have the toxin B gene there. And so what we saw was that we actually saw a decrease in our overall first screen positivity. Again, we were then harnessing and still are harnessing the increased specificity of that first line test as opposed to GDH. So again, just a reminder in terms of diagnostics, please beware of poor performing assays. There are poor performing GDH tests, toxin AB tests, and also nucleic acid amplification tests. What we saw was that when we introduced NAT, we saw this reduction in our laboratory test positivity, and we feel very confident that nucleic acid amplification tests better identify C. difficile excretors that we should be concerned about. We should be using a two-step algorithm, and NAT is the preferred primary test for CDI laboratory diagnosis, in my opinion. Moving on to typing. Historically in the UK and Europe, we have been using PCR ribotyping to type C.Diff where we want to investigate potential transmission events. This looks at a very discrete portion of the genome, only 250 to 600 base pairs, but has been the mainstay of our typing for many years now. In the US, pulse field gel electrophoresis has been used for many years, and up in Leeds they use MLVA as a second line assay where they believe that strains may not be related using PCR ribotyping, and they want to have a higher degree of discrimination. As I've already mentioned, whole genome sequencing can be used now for C.Diff typing, as well as typing, of course, of many other pathogens. It looks at a much larger proportion of the genome than any of the aforementioned typing schemes, looking at about 80% of the 4.3 million base pair genome of C.Diff. It has the benefits of being highly discriminatory, more so than any of those tests that are on the left. It has the ability not only to categorize strains into type, but also to provide information around strain relatedness and evolution. The methods can provide us with methods that are less subjective in terms of their interpretation, and there is a large degree of automation in terms of isolate processing and also result analysis. And of course, as well as typing, you can also get other very helpful analyses from whole genome sequencing data, such as resistance and virulence gene detection. So here in Wales, we use whole genome sequencing to type approximately 90% of our PCR and GDH positive samples, which are referred to the UK Anaerobe reference unit. Once we have this SNP typing data, we distribute the information through our laboratory information management system, as well as an infection control system, which is used across Wales. And in addition to those, we also send out email alerts with strains that we see that are highly related to provoke, hopefully, an investigation where it may not have been recognized that strains were transmitted previously. We have a lot of support from our health protection and pathogen genomics colleagues in terms of surveillance and further analyses outside of the typing. And we're looking forward to, again, thankful to our pathogen genomics colleagues for their work in allowing us to get routine antimicrobial and virulence determinant detection, hopefully as of the end of February 2026. And then we're hoping later on in the year or in 2027 to be able to get better data visualizations tools to support our clinical and infection prevention control teams too. So what we see from the use of whole genome sequencing is it really supports the investigation of periods of increased incidence and potential outbreaks. It can help to rule in transmission very confidently, but also rule out transmission where epidemiology may be pointing towards it, but it actually isn't the case. And we have found it also not only just within Wales, but also nationally within the UK and internationally to be a really useful method to be able to help us to inform and understand outbreaks, to be able to respond very rapidly to strains of concern such as ribotype 955. Because of our excellent coverage and the way that we share our information, it really helps us to get these type of information out to health protection and also to clinical teams. And we've been able to support other countries, both here within the UK and in Europe, looking at strains of concern. So ribotype 955 was one of these strains recently, where we saw 2 very large outbreaks in England. It's similar to ribotype 027, where we see mostly hospital onset, hospital associated cases, and again related to often outbreak settings. We did find several cases in Wales, and a couple of those actually had links with healthcare in England. But interestingly, none of the other UK nations other than England and Wales had seen any cases of ribotype 955, although it's important to remember that, like England, both Scotland and Northern Ireland have fairly low coverage in terms of their C.Diff typing compared with Wales. One of the particular concerns with ribotype 955 was not only its propensity to cause outbreaks, but also the potential for metronidazole resistance. And we saw metronidazole resistant strains in both the UK and Serbia, although these were distinct genomically. And interestingly, none of the ribotype 955 isolates that were found in the Czech Republic or in Slovakia had metronidazole resistance. In Wales, we were very, very fortunate because we have this joined up healthcare and health protection public health mechanism that we were able to very quickly identify, again, because of our broad coverage using whole genome sequencing, what extent of a problem there was here in Wales, which ended up being very small. We were also lucky to have access to rapid C.Diff PCR in all of our labs in Wales that allowed us to prospectively then look out for these strains because ribotype 955, as with ribotype 027, having the TC-DC deletion. And so we were able to say to labs that where there were any concerns clinically of potential outbreaks, with this strain, that we could use those rapid tests to get a presumptive identification very quickly before it was sent to the lab for confirmation typing. And of course, in the Anaerobe reference lab, we have high capacity for strain antimicrobial susceptibility testing and further characterization. A little bit now about the C.Diff Trust. It's a fairly recently established charity for the UK and Ireland, with a vision to end the harmful impact of CDI across the UK and Ireland. Our mission is to mobilise and support the community by empowering people living with C. diff and those caring for them, importantly, but also supporting healthcare professionals so they have the right information at the right time. We are also trying to foster collaboration and alignment between all stakeholders to influence holistic patient-centred guidance and policy. And you can see there on the right myself and the other trustees at the recent launch of the charity back in October. The charity was launched at the Combating CDI conference that we try to hold every 1 to 2 years, and the focus of this meeting was turning insight into action. And so I just wanted to share a few of the insights that came across in that meeting. And so some of the things that we talked about was that the usual healthcare risk factors are still there, of course, in terms of C. diff infection. But of course, we are seeing this increase in the community cases that really does warrant further investigation in terms of, what is it that's causing this increase in our community cases. Again, we were reminded that many community cases can be missed because of the selective diagnostics that we perform for community diarrhea. And also we were taught that potentially we need to revisit diagnosis in younger children, so those 2 years old and younger, as actually colonization may not be as common as research from 20 to 30 years ago suggested. And there does appear to be potentially increasing rates within these settings as well, within these cohorts of the community. Unfortunately, there are very few CDI antibiotics in the pipeline, and some of those that have been in the pipeline for a number of years have been canned by the companies that were investigating them. And again, unfortunately, some microbiota treatments that are licensed in the US can't be used in the EU as regulatory bodies feel the necessity to relicense them in the EU, which the companies that have licensed them in the US aren't willing to pay for at the moment, and so they're not available. Interestingly, there was a lot of talk about nutrition and the potential future of pre-probiotics, certainly around increasing our understanding of the potential use of these, and then also the use of single domain antibodies, which potentially can be used as supplements, and these single domain antibodies could, for example, provide protection from C. difficile infection by binding to C. difficile toxins, and so that's a very interesting potential future development. Something that wasn't mentioned at the meeting, but I thought I'd just slip in here, is that ourselves and some other researchers in the UK are looking at the potential to investigate further the use of vancomycin and potentially fidaxomicin for the reduction of recurrence in patients who've previously had C. difficile infection and subsequently go on to receive antibiotics for other infections. So that's something that we're excited about hopefully taking forward. Day 2, we talked a lot about prevention. There was people talking about the use of C. diff isolation wards, about the importance of environmental cleaning, and of course staff, patient and carer hand hygiene. HPV programs really important, including not just the areas where we have these C. diff patients and outbreaks, of course, but also in things such as shared toilets on a rolling basis potentially. The impact of the concentration of hydrogen peroxide was discussed, and also there was a discussion around the relevance of targets and whether these are actually useful or not in preventing infections. More and more centres in Europe are using whole genome sequencing, And so it really does seem as if the tide is turning away from PCR ribotyping slowly. And we had the lead CDRN again telling us about the developments that they have there in terms of PCR ribotyping and MLVA, and now their Sentinel whole genome sequencing surveillance, which started last year. And throughout the conference, there was a real focus on patient and carers. This is just some patient experience that I shared at the conference, just again to highlight the importance of C. diff infection for individual patients and their families, and of course the healthcare system. C. diff isn't just a mild infection that goes away once we've treated it, and patients never have to worry about it again. They can be very seriously affected initially with the acute infection, and then the sequelae after they are treated can last for months, if not years, especially where they have recurrent infection. So this particular patient who shared their experience with us really wanted everyone to know about how devastating C. difficile infection can be. They said it's not confined to hospitals or very elderly patients. This was a patient who was in their 50s, and it can happen just after a single course of antibiotics. The take-home messages that she wanted to share was that C. difficile infection can have a long shadow, both physically and emotionally. And so that's something that we do need to be aware of. And I'd urge you to have a look at the C.Diff Trust website, and potentially, if you're able to, use the QR code there to donate to the charity if you're able. So in conclusion and in summary, C. diff still poses a very great threat to patients and healthcare systems across the UK and the world. It remains a clinical diagnosis despite the tests that we have. And nucleic acid amplification tests should be our primary screening test if feasible, and those potentially with TCDC deletion detection capability can be useful, especially in the setting that I've discussed with the ribotype 955 problems that we had. Whole genome sequencing, SNP typing really is going to become, well, not necessarily SNP typing, but certainly whole genome sequencing, potentially core genome MLST, will become the frontline typing test in time. Lastly, patients and healthcare professionals need more support to do the right thing at the right time to improve the prevention and management of CDI, which is why the C.Diff Trust was set up, and why C. diff is really of importance even in 2026. So thank you for your time, and I'm looking forward to taking any questions that people may have.
Hi everyone, and thank you for joining our webinar today, and thank you to Michael Perry for that very interesting presentation. It's my role now to present questions from the audience who've been listening. What tends to happen is they pop up as at this late stage while I'm presenting, so I'll have to read and read them off the screen. First of all, we had a question from our social media channels about treatment of C. diff infection, something you touched on briefly. Can you fill us in a bit more about the role of fecal microbial transplantation and also define bacterial consortia in C. diff treatment?
Yeah, of course. It's interesting, isn't it, that we treat antibiotic-associated diarrhea with more antibiotics. And we know that vancomycin, of course, is the first-line treatment according to the NICE guidance, an antibiotic which is fairly broad spectrum still. We have fidaxomicin as our second-line agent that a lot of people actually use as a first-line agent according to risk for recurrence for their patients. But FMT currently under NICE guidance is the third line treatment. And so where vancomycin and fidaxomicin have either failed or prevented to not prevented a second recurrence, then FMT is indicated at that point. Bacterial consortia are still mostly under investigation in various phases of clinical trials. And I think, they have shown, good potential. But until those come online, we are sort of still looking at the use of FMT. Unfortunately, FMT is massively underutilized. I was at the Birmingham MTC Microbiome Treatment Centre yesterday and on Monday, and they estimate that not even 10% of patients who should get an FMT are getting one. And that's for a variety of reasons. But yeah, it should have a much greater role than it does have, FMT. It is a NICE approved therapy for C. diff treatment. And it's interesting that when you speak to patients and they say, yeah, why are you giving me an antibiotic for antibiotic-associated diarrhea? Wouldn't it be better just to give me FMT straight away? So it'll be interesting to see how things develop in the future, especially when these bacterial consortia come online. I do hope that we will have a better way of treating C. diff in the future, and certainly means that will prevent all the recurrence that we currently see that really not only blights the patients' lives, but also costs healthcare systems a huge amount of money.
Sure, yeah, thank you very much. And following on from something you said there regarding antimicrobial therapy, is vancomycin resistance an issue with C. diff? And if it's present, is it increasing?
Yeah, so there are reports of vancomycin resistance in C. difficile. None of these have been confirmed by reference laboratories as yet, but there's certainly, theoretically, the possibility for C. diff to get resistant to vancomycin. And also we know that we have also seen sort of increased MICs that have been confirmed by reference centres. So it's definitely something we should be worried about, or at least looking out for, but it's not something that appears to be causing a huge clinical issue at the moment. Having said that, there is some theory that effectively, potentially, those higher MIC strains may be the ones that go on to cause recurrent infection. Again, the evidence is lacking there. There's no firm evidence either way, but it stands to reason, doesn't it? As with everything, when you effectively use a sole antibiotic to treat an infection, at some point in time, that antibiotic will become less and less useful. We've seen that with metronidazole, which is why metronidazole is no longer the frontline treatment for C. diff infection. And I'd imagine that we will see that for vancomycin if we carry on using it the way that we are, the way that we were using metronidazole beforehand. So definitely something to be concerned about and keep a lookout for, and something that we need to, not only as reference centres, but also as diagnostic labs, I think, in the future. We do need to be keeping a better eye on antimicrobial resistance in C. diff. It is curious that, pretty much any other bug that we treat with an antibiotic, we look for resistance in. With C. diff, we do that very rarely.
Yeah, that makes a lot of sense. And we've got some questions popping up now on the screen. Thank you for this overview, Michael. How do you look at the emergence of RT955 and related ST1 types in view of the general downward trend? Are we missing something, or have we become too easygoing on C. diff?
Yeah, it's a really interesting question. As I said, so in terms of our very broad testing for typing for C. difficile infection, I'm very confident that we're not missing anything here in Wales in terms of a ribotype 955 problem. I think where it has happened is, ribotype 955 appears to behave very similar to 027 in that if we don't do the things that we know we should do, if we don't catch, cases of diarrhea early, and if we have patients in a situation where they are very vulnerable to C. diff, then we will potentially see quite large outbreaks with this strain. I think in the main, because we are so much better these days in general at preventing C. diff, That's why we don't see the same problems as we used to see with ribotype 027, and I think we're unlikely to see them with ribotype 955. There's definitely this shift in, I think the precautions that we have put in place since the early 2000s have shifted the challenge with C. difficile infection to very much sort of a community setting now, and also within hospitals, probably just smaller, discrete outbreaks in the main. And sort of, these potentially hypervirulent strains then can't do what they're good at doing because of the things that we've put in place. What we need to do now, of course, is try and relearn how to treat C. diff, how to prevent C. diff in the way that we see it currently.
Yeah. Okay, next. The current two-step diagnostic algorithm incorporates a low sensitivity enzyme immunoassay platform introduced in the 1990s. This approach is missing a significant number of positive cases due to its low negative predictive value. What strategies or recommendations would you suggest to address this issue?
Yeah, it's a really good question. I would go back to what I said a couple of times in my presentation. C. diff has to be a clinical diagnosis, aided and guided, of course, by the tests that we have. But there is no getting away from the fact that we just don't have a good second-line test currently. I am hopeful that the ultra-sensitive toxin assays might come to help us in the coming years. Although from the work that we've done with companies with these assays so far, they seem to align quite closely with PCR. And so potentially, they may not be that helpful if effectively what we see is that if a C. diff strain is toxigenic, then it is always producing toxin, just at different levels. And that actually maybe it's not necessarily the whether it's producing toxin, but how much toxin it's producing and how much bug there actually is there. So it's really, really tricky. So I would just come back to use the best tests that you can, both the frontline screen and the toxin EIA. And yeah, just make sure that it's always a clinical diagnosis, make sure that patients who are toxin negative are being assessed clinically and not just discarded. Oh, they're toxin negative, they couldn't possibly have C. diff. And also from a prevention perspective, always bear in mind that even if a patient is toxin negative and doesn't clinically have C. diff disease themselves, that doesn't mean that they cannot transmit their strain through their diarrhea into the environment to another patient, healthcare professional. So just mindful of the holistic approach to patients with a C. diff negative result.
Yeah, of course. And following on from that, we have a viewer describing a scenario where they've tested 100 IBD patients and only one of them found to be positive for C. diff toxin A. They're skeptical of positivity because they did GDH and toxin A and B by mini-VIDAS and then did PCR too. Got 6 positive for GDH but negative for toxin. An ELISA-based assay detected many positives for the same samples. What do you say about the right diagnostic test algorithm?
I'm struggling to get my head around that one, I have to say, Andrew.
Okay.
What I might suggest is that if I can read that one through post here, I'll get my head around the nuances, and I can provide an answer through Don Whitley Scientific
sure.
to this. And I think that's probably best rather than me thinking that I've got it but answering one question.
Yeah, absolutely. So I'll move on. I'll say to all the audience, we can follow this up afterwards and they can contact us by email and carry on the dialogue that way. So moving on there is not a complete agreement between PCR ribotyping and whole genome sequencing. For instance, hypervirulent strains belonging to clade 1 can be discriminated by PCR ribotyping into various groups, but not by whole genome sequencing. This is another rather long question, I'm sorry. It's likely that RT955 would not be recognized by whole genome sequencing. So, shall we continue with both PCR and WGS?
So our experience with ribotype 955 is that we can recognize it by whole genome sequencing. It clusters in the broader sense with ribotype 027, but when you get down to those sort of fine single nucleotide polymorphism margins, that actually they do cluster amongst themselves. So that's not our experience that you can't. Potentially with core genome or whole genome MLST, that may be a problem. In which case, that is something for us to think about. My personal feeling is that PCR ribotyping, whilst it has its benefits, it will now become a thing of the past. My understanding from a colleague that I spoke to in Europe is that more centres now in Europe are using whole genome sequencing than actually PCR ribotyping. So I think we are moving away from PCR ribotyping, which I think is good. Having been a centre that did it for many, many years, and actually the centre that that developed it initially, PCR ribotyping is not straightforward. It is quite difficult to standardize, quite difficult to perform. There are still ribotypes that some centres can differentiate, other centres can't. So I think the standardization, the automation that whole genome sequencing will eventually bring in, I think will lead us to go down the whole genome sequencing route. We will probably need to do core genome or whole genome MST as sort of our front line. But then subsequent to that, because that's easier to standardize between labs. But then subsequent to that, I think we'll probably use SNP typing, which I believe, and as I say, our experience with ribotype 955, it does distinguish it. So that would be how I would approach things in the future, and I think it will sort of fall out.
Thank you very much for that detailed answer. I think that'll be really helpful for the audience. And I think, unless we have any late entries, I've just got one more, and it's a simple and short one. How fast should we do toxin assay after collecting stool samples, and does storage at -20 degrees cause false negativity?
Yeah, so how fast? Just as fast as you can, just as with any assay. The quicker that you can do the assay, the more likely you are to get a correct answer. There's sort of some data out there that would suggest that toxin degrades quite quickly, other data that suggests that it doesn't. Certainly, storage at -20 can degrade toxin, it can degrade nucleic acids. So potentially, -20 storage could cause false negativity. Ideally, we always test a fresh specimen that is as fresh as it possibly can be when it gets to us. I don't think there's any, actual evidence-based, rights or wrongs about answers to that question, unfortunately.
Brilliant. Thank you very much, Michael. I don't think there are any further questions unless someone's in the act of typing one. So I'll just say thank you very much again, and thank you to the audience for taking part.
You're welcome. Thank you.